Welcome everyone. Thank you for hosting us in the great city of Madras. Just love to see all the economic development and investment that's going on in the community. It's really, really cool to see. Let's go ahead with introductions, and shall we start? Carmen, do you want to kick us off? We'll go around the room.
Okay, great. Carmen Madrid, Executive Director for Central Oregon.
Getting in on almost
a year.
Oh my God.
Yeah.
Yes.
Month. We're having a party.
Yeah, exactly. Yes. Brad.
Brad Porterfield, Consumer Representative, Chair of the CAC, and Executive Director of the Latino Community Association.
Groovy.
I'm Rick Trelevin. I'm the Jefferson County Community Mental Health Director. I'm CEO of Best Care Treatment Services, and as an LCSW, I'm your behavioral health seat at this council.
Excellent. Thank you. Patty.
Patty Adair, Deschutes County Commissioner, and I have to share this teeny little story. I don't know if you guys know Colleen Sinsky or not, but I'd always seen her name, and I kept thinking, I wonder if she's related to Dr. Sinsky in Santa Monica. Yes, she is. It's her uncle.
Oh my God.
Is that amazing?
Yeah.
Yes. And we'd actually eaten dinner at his house. He, very famous doctor in LA, and he has a great vineyard.
Oh, that's great.
And her father is a doctor, too.
Oh, my goodness.
Yeah.
What a small world.
I know. I'm just
Okay.
thinking.
Yeah.
It's
Well, and does everyone know that you and my mom are cousins?
Oh, that's right.
So,
I know, it's actually funny.
I mean, really, we're just all family.
I know,
right?
I'm funny about that one. It is, it's
Okay.
hysterical.
So I'm Tammy Beatty. I'm your chair and tour guide for today. And Camille, and then we'll go to Whitney.
I'm Camille Smith at the Central Oregon Health Council.
Wonderful.
Hi, Whitney Schumacher, Central Oregon Health Council.
Hi, Dustin Zimmerman with Oregon Health Authority. I'm here.
Great.
Tricia Wilder, I'm the CEO Director for Central Oregon. Hi, Leslie McBauer, Shaker Pronouns, and I am also a first hairdresser.
Awesome. Kelly.
Kelly Adams, Oregon Health Council.
Great. Megan.
And Megan Boyle, Director of Operations.
And Megan and I may have attended school together. So we're really just,
There is such a mafia running. I'm so sorry.
Oh, yeah, you're either part of the family or you're not.
Well, of course, we all know Jefferson is run by the Aherns, so.
It's true, yes. Kat.
Yeah, that's Director of Volunteering.
Wonderful. Dennis.
Presto, Director of Social Services.
Excellent.
Miguel Ángel Ebrada, Central Oregon Health Council,
Excellent. Uh-oh, Bacon. Dr. Baker.
Mike Baker, Jefferson County Public Health. I'm welcoming you here. We haven't had a chance, I'm sure you walk just across the parking lot, the brand new Health and Wellness Center, which is co-located with Jefferson County Public Health and our Federal Qualified Health Care Center, Mosaic Medical. It's a beautiful facility. It has a medium room just like this, probably even better. So if you want to have feel free to go over there. Happy to give a first one.
Okay. Old dog, new tricks, so we will know that we have another option. Excellent.
Are
And
you
that's
calling Michael Baker a dog?
No, I'm saying us. This is usually where we meet in Madras, so now we have another option. Thank you. And that facility's been open how long?
We're coming up on a year.
Wow, that's really exciting. Okay, great. Thank you.
And he does have a dog. You had an Aussie last time I saw.
Well, we're both working on that COVID weight that we both had to gain in the last 3 years.
I love it. Michaela. Great.
And Wendell, Jeter is also project manager.
Groovy. All right. Megan.
Megan Hayes, Mosaic Medical and Health Council Finance Committee Chair.
Excellent. Nice to see you. We are one person shy for a quorum, so we
No,
are. Yes.
Kelly's done.
Oh, I think we still need one more. Let's do a quick head count again.
And I did send a message to Seth, too.
Okay, thank you. Dan, let's go to you.
So we need 8.
Sure. Hi, everybody. Dan Stevens, board member, and I'm from Pacific Sourcing.
Excellent. It does look like you're in a jail cell, but we're going to hope that.
They quietly caught up to him. I see.
Just Just calling that out. If you
Solitary
need us,
confinement
you
with a
know.
window. Yeah.
Oh, pass a hat for bail.
Okay. Okay. I see Commissioner Simile. Would you like to introduce yourself?
Hi,
I don't
everyone.
know.
Welcome
I
to Madras. I'm sorry I'm not there. I've got a lot of commitments today, so I appreciate you being here, and I am here, so.
Excellent.
Is that the plant we gave you in fact?
No, it's over here on behind the computer screen. No, that's a rescue. We call it a rescue. I stole it from a neighboring company that had let it die, and I brought it back to life, so. We're good.
Oh, wow. Love it.
You have a green thumb?
Okay. No. Oh, you do have a green thumb. Nice. All right. Just learning a lot today. Okay. Let's go to Carol.
Hi. I'm a temporary assistant working with Carmen and the team for a short-term contract. And hello, Patty.
Wonderful. Thank you for joining us. Jeff.
Hello, I'm Jeff Davis. I'm the Pacific Source Central Oregon Medicaid Medical Director.
Excellent. Erin.
Good afternoon, Erin Fair-Taylor with Pacific Source.
Wonderful. Thank you for joining us. Jessica.
Good afternoon, everyone. Jessica Waltman. I am the Health Services Quality Assurance Director for Pacific Source. Thanks for the invitation today.
Yes, thank you for joining us. Have I missed anyone? Okay, so we are still phoning friends for, yep. Okay, well, we will continue forward. So we've handled the introductions. Go ahead with announcements.
Okay, sure. So just a note that the board retreat will be happening Thursday, June 8th. You should have received the calendar invitation from 10 a.m. to 5 p.m. So please RSVP to Camille so we can coordinate all of the logistics around it. And speaking of how everyone's cousins here, conflict of interest statements will be going out. And it's headed your way for signature, and this is just something we do annually. And then last but not least, our board self-evaluation surveys will be going out to board members. And if you could please complete those by Friday, May 12th, we have a month to do them, and they will inform what we will be sort of working on at the board retreat. So we would love your participation.
Wonderful. Let's go ahead with comments, public comment. Is there any comment that anyone would like to bring forward? Okay, seeing none, then we will go ahead. Let's just carry forward. I don't know that we won't be able to approve the consent agenda, but we can go on to grievances and appeals. So Jessica, may I turn it to you?
You absolutely may. Thank you so much. Are you going to be there sharing screen? Great. And I believe I had a slide deck that I had sent over. Great.
And we are pulling it up right now.
Yeah, I can see it coming through for me.
Oh,
Do we
good.
need to give
Okay.
it a little bit of time for others?
I think we're good.
Okay, great. So just introduce myself. So reintroduction, quick to level set. My name is Jessica Waltman. I am the Health Services Quality Assurance Director here at Pacific Source, and that encompasses oversight and accountability of our appeals and grievance team. We can go ahead and go to the next slide. One of the areas of level set for all of you, I wanted to just round back on is the differences between appeals and grievances. As they're sort of bucketed into one statement, they are two very separate and distinct processes and items that serve our members and our CCO population. Appeals are absolutely those items that are requesting reconsideration of a denial, such as for a pre-authorization or for a claim denial. Grievances are any expression of dissatisfaction, and these two processes, these two rights can actually run parallel to each other. So they can be running at the same time concurrently and being processed at the same time. So I wanted to talk through some of our strategies for this year in relation to our appeals and grievances. Because we are able to use this data to determine what kind of trends of dissatisfaction, areas of opportunity that exist, we use that data to inform strategies. One of the things we are going to be focusing on in 2023 is incorporating more of the RealD data into the analysis of our appeals and grievance data to determine what areas of opportunity exist between those who may have translation needs or other impacts. Previous years, we have strategized on ways to create some equitability as well as diminish some of the intensity and fear that exists within those processes, acknowledging that those two words, appeals and grievances, are intimidating for members. And we've received some really good feedback, such as from our CAC, as well as directly in collaboration with the state, and have made some really significant progress. Another area of strategy is increasing our transportation benefit awareness. We send out survey data to our members and then specifically inquire, do they even know about the transportation benefit? This is a direct correlation to access to services given transportation barriers, and this benefit is really important. But what we were seeing historically is that there was actually a fairly high % rate to no. Members are not aware of this benefit, which was surprising. And so we're continuing to put forth strategies to raise awareness, whether that's through mailers. We have launched a new website and we have put that information about transportation and information about that in an easy, accessible manner, 1 or 2 clicks to be able to find that in an effort to improve that. And then the other area of strategy is going to be around the satisfaction of the transportation benefit. We continue to see a high volume of complaints in our Central Oregon population referring to dissatisfaction with transportation. And it runs the gamut. It can be timeliness of ride pickup, it can be interaction with driver, it can be interaction with call center related to the transportation benefit. And so we partner with brokerages and meet with them on a regular consistency at minimum of monthly and work to strategize ways to improve all of those impacts coming from that complaint data. It has been positive thus far, but there is great work to be done. We've set a pretty high expectation in relation to we want to move the measure and the needle on the amount of complaints that we get related to transportation. And so we've set a pretty rigorous benchmark that we're very confident we're going to be able to meet in that partnership with our transportation brokerages. The other and final area of strategy that I wanted to talk about today is the dental health access. While we have fairly small numbers related to complaints and appeals for dental health services, it is known that continuing on with the discussion around dental health access, it is definitely known in our communities. We're hearing absolute feedback regarding opportunities related to dental health and access. And that is something that we're partnering directly with to recruit and identify staffing shortages, as well as scheduling barriers that exist within dental health. And we have meetings with our DCOs on a regular, typically quarterly, but we're looking to strategize and see if there's an opportunity to have smaller work groups in effort to address some of those challenges that we are seeing and hearing in our complaint data. So
yes, we do have one question for you.
Okay.
Okay, go ahead.
I just have a quick question, Jessica, on the transportation benefit. Is that across all lines of business, and who makes that request in the process? Is it the provider or is it the patient?
Primarily, the patient is requesting the ride, and it is specifically for the CCO Medicaid membership. There are some overlaps of benefit for transportation with our dual population in our DSNP plan, but this strategy is specifically designed and designating working on the satisfaction and benefit awareness for our Medicaid population.
Okay, thank you. Yeah,
You're
we have
welcome.
another question.
Can you hear me?
I can.
Can you hear? Okay. So I'm just curious, the NEMT, non-emergent medical transportation is 26.3% of the grievances. What other large areas rise to the top in terms of grievances, most common grievances?
Dissatisfaction and interaction with providers. That category is very broad though, so I want to go into a little detail. It can actually be the interaction with a front desk individual, not specifically the care delivery provider, because we look at that relationship and all of the components of that provider office as one. So oftentimes it can be interaction on the phone, can be interaction in the waiting room. Their service related, not quality of care related. And so that's a differential I want to call attention to. Also, dissatisfaction with benefit understanding in general. Those would be two probably equivalent categories of complaints that rise to the surface in volume right below the transportation benefit.
And just one follow-up question, is there any correlation or association with any particular group, and I'll just raise up Latinos or folks who have language access needs?
That's a really great question. And I think we're learning and discovering there. That's part of one of the strategies we have around incorporating the correlation in that REALD data against the appeal and grievance data to better understand that.
But no conclusions yet?
None yet, no.
Okay.
Can I ask a question? So Jessica, I was curious about if there's consideration of Lyft and Uber as part of the suite of resources for transportation.
I know that has come up in discussion. I'm uncertain as to where things have landed there. That would be some information I'd want to get back from our provider contracting and folks who are working directly with those brokerages to in that strategy that I would be happy to round back here with.
And this is Erin. I can speak to that briefly. And it is the way that Uber and Lyft contract with drivers does not enable us to credential drivers in the way that Medicaid requires of us. So at this point in time, Uber and Lyft don't meet Medicaid regulatory standards. I know they're working on that, and we're in active conversation with the state around how to address some of those regulatory barriers. But at this point, they don't meet those standards.
Got it. Thank you for your advocacy, though.
Okay, I think that's the end of the questions for now.
Well, that pretty much sums up my presentation here. If there's, I wanted to include some context for distribution here on how to contact our team. If there are further items to discuss or continued sort of touch points on this subject, I would be happy to bring those forward in future meetings.
One of the things that might be on the transportation piece is that a couple of years ago, we transitioned from the brokerage in our region. And I'm wondering how we were doing. I know it wasn't great prior. Access has always been a challenge. If there's a way to see how we were doing at that point, how we're doing with the new contractor, and then also how it's been in other regions with the sort of growth within one contractor versus contracting with a brokerage that might be more specific to community or region. I don't know if that's a great way of asking it, but Rick, go ahead.
And I know anecdotally amongst my staff, I think the current transportation has major staffing issues.
Yeah.
And so they're fine, they just don't have the staff to cover a lot of needs. So we all have staffing issues. Well, it's I know your organization's stuff, but Best Care has staffing issues. So I'm not throwing rocks at an organization for their staffing issues, but that is the concern that we hear.
It's an issue on the dial-a-ride and the public transit side too, and so I just was, not sure of the narrative of the story that's behind that. Did you have an answer, or are you prepped for the next?
I'm ready for the next.
Okay, excellent, all right.
No answers.
Okay. So, Jessica, thank you.
While we have Jessica still with us.
Oh, go ahead.
I was just going to add on to that additional comment about transportation, and one of the questions around correlating the previous brokerage, the new brokerage, and comparing sort of the success or opportunity that exists between those two. One thing anecdotally that is a little challenging in looking at that data is the impact of COVID. That really changed the environment in so many respects. And I heard someone also talk about the staffing challenges with transportation. We found in our conversations and discussions, the challenges exist in a pretty expansive way that are outside of the delivery system and the health system in general, such as fleet, the cars, vehicles, the actual mode to provide that transportation, and servicing those vehicles is also an expense and a staff limitation that the results of COVID kind of created in the economic constraints that exist to a number of spaces. So those are some of the unique challenges that are also embedded into those strategies and finding those ways to work through staffing as well as sort of the equipment side of actual transportation. Anyway, I just wanted to add that as some additional flavor there.
Thank you. It definitely helps to paint the picture. Okay, so redetermination.
Yeah.
That is a big deal. So go right ahead, Tricia.
Thank you. Jessica, if you're still here, I just want to also let everyone know 2 out of our 8 performance metrics that we track quarterly. Jessica provides all the information on the grievance and appeals sections for the oral health and the NEMT. So I just want to shout out to Jessica, she's still there, for her work and providing all that supporting information and for the great work that she does every day.
Nice job, Jessica. Thank you.
Thank you, Jessica.
All right.
Happy to participate. Thanks, everyone.
You bet.
Thank you, Camille. Let's jump in. So redetermination was this thing that we talked about for a long time in this space, probably the last year and a half at least. I've been providing updates. When will it start? How will it begin? It has begun. So on April 1st, redetermination began in the state of Oregon. That does not yet mean necessarily our members have been contacted. That is happening, but the state has enrolled the process and is now identifying what members will be redetermined in the month of April, and so on and so on. And we're going to talk about what this timeline looks like in detail. We're going to talk about some action points that we can all take away from this phase, and that's also an offering from resources as we go forward here. So just a few highlights. We can go to the next slide. Not Kelly, thanks. So important to note that OHA manages this renewal process. This is not a Pacific Source specific process. OHA is doing this across all CCOs. So they'll check eligibility and notify the member, and then subsequently each CCO of that member's eligibility. So just a reminder on that space, Oregon redetermination will take 14 months to complete. I believe we have either 10 or 12 months to start the process and 14 months to have that process be complete, and we'll show you what that date is on a subsequent slide. Members have 90 days to respond to initial renewal requests. That's significantly increased, and we're going to see the benefit our state put on ensuring that our members have the best, longest duration possible to respond to inquiries, which is pretty incredible in the state that we're in and the choices that our leadership is making. Then we're going to talk about two upsides in this process, the 1115 waiver, which anyone who renews after April 1st will experience continuous eligibility for kids aged 0 through 6 years old. There will also be a benefit for 6 to 19 years old. We'll talk about that in a moment. The last great part of this process is that there will be, at the end, a new basic health plan created that will be implemented in 2024 for current members of July 24. And then any new members could be part of that program in January 1st of 2025. So this is a long game process. And again, we'll cover some of those specific dates in subsequent slides as we move forward. All right, so this is that OHA slide demonstrating how many members currently have coverage. And I'll share that the 1.4, and Dustin, who's with us, can probably also say that that's closer to 1.5 million now. So anytime a slide gets printed, there are immediate changes after that, which is why I'll continue to report updates as we go along. This is a very, very dynamic stage. But OHA is estimating, 1.1 of those members will continue to be enrolled in Medicaid. So I think this is a good big picture so that we're looking at the bulk of the membership continuing to have eligibility throughout this process. However, right now, the current estimations are probably a little bit greater than 300,000 members across Oregon will no longer qualify for Medicaid. Those people will go into different programs. One, potentially the Bridge program that leads to the basic health plan. The other is they may now be eligible for the Marketplace, not eligible for Medicaid. And then where we sort of hope most of those people have is that Medicaid has been acting as a secondary to their employer coverage, so we're most hopeful that the bulk of those members will fall in that space. But there are many, many unknowns. And then, of course, whenever this happens, there's this unintended consequence that some members will be uninsured. Go ahead to the next slide. Let's talk a little bit about what this means for Central Oregon. We just tipped over in our data in February over 75,000 members, which every single time I report this is an all-time high for our region. We have grown in Central Oregon 40% since the public health emergency was declared in March of 2020. Really significant growth. I think the important note in that space is that the state is estimating that the CCOs that grew the largest also have the highest potential for decrease going forward. So something to keep in mind as we've experienced so much growth. And again, I had a good question yesterday. I did this presentation when I was asked, is that because new members joined? Yes, but it's also because nobody, Hotel California, nobody exited Medicaid in that space. That's the compliment of my manager.
Great reference.
Yeah. Yeah. Never get out.
Yeah.
Nobody left Medicaid. That was the continuous eligibility that happened during public health. Where again, just as a broad reminder, this is a normal process. We did this every year with all the members. So we are simply returning to a process that used to exist that was just put on hold while the public health emergency was in place by the federal government. And then lastly, we're anticipating about a 6% reduction in 2023. And I know that there are members here listening that have heard this number higher. Some of this potential estimate of reduction of 6% has decreased because of the long duration members have to respond, which is incredible. But that means that it puts even more pressure on 2024, as ultimately by the end of redetermination, we'll be looking at about a 25% reduction in membership. So essentially 1 out of every 4 Central Oregonians will no longer likely qualify for Medicaid moving forward. So when you say this is big, Tammy, this
Yeah.
is really, really big.
Yeah.
Yeah.
Right.
Sure.
Question, so the one thing that occurred to me is wages went up pretty considerably in the last 2 years. So is the eligibility level, does that also go up?
So yes, and I think this is one of the really exciting parts about the bridge and basic health plan that Oregon is about to implement. So traditionally, the Medicaid threshold has been 138% of the federal poverty line, and now that has been elevated to 200%, which is a significant change. And the members that typically have fallen between that 138 to 200% threshold for some of what we call churn population, people who are 1 month qualifying, not qualifying, on and off Medicaid, kids on and off Medicaid, incredible disruptions to healthcare, population health, to the system as a whole. So it's really exciting that our state is taking that next action. And so we're calling it a bridge program. So all Medicaid ceiling has been lifted to 200%, and then eventually we will meet that new program at 200%, and I've got a slide to address just that. So it's a great question.
Didn't the federal poverty level go up to more than it had in years past?
So on that question, I
Yes.
would do it. Just brings me joy when you ask Erin.
I jumped in. I anticipated your need, Tricia. Yes.
The voice of God, oh my God.
Everywhere I
Knew what
go.
you were thinking. And,
Everywhere I go.
It's spooky.
Joyful.
Now we're, yep.
Thank you, Erin.
County, the perks, being in Jefferson County, you get like divine intervention.
Divine intervention. Yeah. I've done a lot of praying in this room.
All right, on that, can we go to the next slide? Great. I think this is a good slide, not so that you necessarily remember automatic, passive, and active are the three types of renewal processes, but I think it's good to just note that in an automatic process, the member actually is continued forward in their benefits, and the only thing they receive from the state is a notice of eligibility informing them that their benefits will continue. So when I think about communication plans and how do we talk to all the members and how could we let everybody know they're about to get all these letters and fill out all the information, there's a portion of members that will never have to fill out anything who will be automatically rolled forward. So I think that's an important distinction in this process. Then there's a passive renewal, which means, the state's like, hey, we could use one bit of information. You can probably transmit it to us electronically. This is pretty easy. If you could answer that, let's get it done. And then the active renewal is what I like to call the full meal deal. You're going back to the whole application. You're filling out all the information. The state says, we don't know what's happened in the last 3 years since we talked to you last. We're going to need some updates from the state. But again, I think the important part of this is to know that there are different ways that our members are being contacted, and some will not have to fill out any information to continue to have their eligibility. Any questions?
Are we, Janice, go ahead.
This might be early, but I just want to paint a picture of what providers of services, so those of us that are mostly funded through Medicaid, and providers. Our population, so the logic, pure math logic would be Medicaid enrollment goes down, our system population goes down. That's not what happened. The people that are in that gap, that were covered during COVID are probably not the bulk of people accessing primary care through FQHC, some public health services. So as those enrollment numbers go down, we lose up to 25% of our revenue. Our service population remains the same. Our costs probably went up 12% in the last 2 years, with a projected increase in that roughly 25% next year. So it's just, I just think it's something for the council to be aware of, that we're going to continue to serve the same numbers of people who truly likely this week after that revenue comes in, and a group of people that are uninsured now by Medicaid as well, who still have needs. So just, I don't mean to do, I'm just saying.
No, but it's a great, yeah. So, with the shared savings with the 1%, and we have part of that going to behavioral health, are those eligible expenses? Can we essentially use savings within our own region and support some of these needs that we know are going to continue to grow? Do we know?
Well, what we know, like for behavioral health, it was 30% across. So that will buffer us a little. But what it means is that a 30% increase in revenue that we've been waiting probably should that's how long it will become an actual 5% fact within about a year and a half. And that leads us back to the
Gotcha. Well, thank you for raising that. I would suspect that it's probably not an entirely different story on the public health side. So, yeah.
The interesting thing, the numbers are the federal poverty level for a family of 4 went up to 30,000 in '23, and for an individual, it went up to 14,580. So significant, it did go up a bit. Just looking at, like, and what is our income here? I think it's something like 66,000, the average family income. So.
Okay, Tricia. Oh, Kat, whoop, we got another question. Yep.
Is that going to be new people coming in or is that is effective right now as of April 1st, the 200%? And what is not explicitly covered in this slide deck either is groups that will be moved to the front of this process and groups that will also be moved to the back. So people who are estimated to be in the higher income level are going to be moved to the back of this process intentionally. So currently the lift is a bridge to get to the basic health plan that includes 200%. People whose income is higher will be redetermined later in the process so that when they're done with that redetermination, they can go into the new basic health plan that will be the 138 to 200%. So it's a temporary bridge that's right now in basic Medicare for just that. So you know, the expansion population that for instance, that will be only for current members on July, and then new members coming into the system, January is when they're eligible for that base. And again, we're going to get to a base health plan. Great question.
So I have a question about finding members. So 90 days to respond sounds like a long time to probably most people in this room, but it's actually if you're in, you've got a lot of demands on your time and you're maybe in crisis or you have just things. I'm sure the state has thought about, 'cause that was one of the challenges, getting people on and access. Is that a concern, and if so, is that being addressed of how we make sure that we're doing the appropriate outreach to make sure that people don't just fall through the cracks by virtue of we didn't hear from them in 90 days?
Yeah, I think that is a multi-pronged question, really good one. We're going to talk about some action items that we can all do.
Oh, good, okay.
Okay. Offerings that we've made to specific provider partners in this space and community partners to help provide materials to do just that, to try to be more on the front side.
Okay.
Let's look at the next slide. So
yeah, sorry, yeah.
I know.
We're like a herd of, yeah, we're like a herd of turtles.
I know. So what this slide is demonstrating is you look across the renewal period.
You can? Yes, please.
So it's a complex slide, but we're going to start here. We're going to walk like a member all the way through this process. So we're going to talk about what 1, 2, and C, and then the 90-day reconsideration period is. When I talk about each of these, I'm going to refer to these definitions. And then we're going to talk about what the meaning at the top. I've been wanting to point on all my Zoom meetings.
Oh, good. Yes.
I can sleep now. So starting April, the state is now sending out notices. Justin, can you give us that? I think we're headed next week for notices dropping in the mail?
That's my understanding.
Okay, that's the target.
Okay.
Okay, all right. So currently working on who will be initially predetermined in this space. So during this time, the one system identifies everyone up for renewal. Magic One system at OHA. And then monthly notices are sent to members, informing them of their status and if any action is needed at that point. So a first letter immediately goes out in April. If you slide across that line, you see number 1, then a reminder notice goes out. Another 30 days later, we haven't heard from that member. We send a second reminder notice. So that is 3 letters that have gone out to that member. If they don't respond at the second notice, another reminder is sent so we get to the end. So let's go down and take a look at what the notice of closure and that 60-day adverse period looks like.
And these are all via mail? Oh, boy. Okay, I can see a big, okay,
That's
yeah.
why there's been that big push to make sure folks are, have their contact information down, which I have to say, gotten a huge response.
Good. Good.
Yeah, you're right, we are already seeing less return mail at our own office.
Oh, that's great. Good, okay. Okay. Good.
Yeah, I mean, there will be opportunities certainly in this space in a mail-driven, process. Let's talk about what 60-day adverse period means. So 30 days after the second reminder, so the number 2, is sent, there will be if there's still no response, the member will be sent a notice of closure at that point. The member will continue to receive benefits for another 60 days. I mean, go Oregon, look at that. It's April 1. You are going to have coverage until October 1st if you never respond. So then it begs the question, well, what happens if a member responds during that 60 days? Wait, that's not all. You also get a 90-day reconsideration period. If the member responds during the 60-day adverse period of the renewal can proceed without a benefit interruption. Woo! After the 60th day, however, if nothing is done at that point, benefits will end. The member will still have 90 days to respond and resume the renewal process when the 90-day reconsideration period ends. A new application must be made. It's important to note all along throughout this that this is an entitlement program, and if a person is eligible, they're entitled to benefits. It just means going back and filling out all the information. But hopefully, they have received mail, and also then step 2, opened that mail, and not put it in the I'm scared of what that could be pile.
Yeah.
So let's talk about a little bit about that as we go forward too. Let's go to the next slide, and I just wanted to show you that slide on steroids. So it is that cycle happening over and over, month after month, until we leave healthcare or we're done with the process. That is roll. So,
It is, yeah.
it's a lot, yeah. Let's go ahead and go to the next slide. All right, so here are a couple benefits of being in the state of Oregon. First of all, the 1115 waiver that was recently granted to the state of Oregon from the Centers of Medicaid and Medicare Services, CMS, granted us the ability to have continuous eligibility for kids 0 to 6. And then I also mentioned what happens to 6 to 19-year-olds. They have 2-year eligibility. And I just feel like this is a pause for dramatic applause.
Yeah, that is big.
This is dramatic, and we are leaders in the country in this space. It's really tremendous. When you get this live deck sent to you, if you want to learn more about the waiver, you can just click below, and that'll take you straight to that information. Let's talk about the second incredible part, which is the basic health plan. And there's only a couple of states, as I understand it, across the country that have implemented a basic health plan. And House Bill 4035 is what required OHA to create a new bridge, this is why I keep doing this, to provide a more affordable, comprehensive source of health care coverage to adults in Oregon with incomes between 138 to 200% of the federal poverty line. So the bridge is now until we get to the implementation of the health plan, and then the basic health plan, and then everything will roll together. Let's take a look at what the basic health plan really looks like when we break it down. Next slide. All right, timeline. Let's go ahead and start at the top left on April 1st, which is about where we are, where the first renewals and requests for information are sent. And Kat, to your question, yes, Medicaid is temporarily expanded to 200% of the federal poverty line. There are some engagement processes that happen in May, and then the goal is that by July 11th, there is approval that gets submitted to the Center of Medicaid and Medicare Services, CMS, to approve Oregon's request for basic health plan. That will go smoothly, and then July 1st of 2024, that program will be enacted at the exact same time redetermination closes in the state state of Oregon. So those two are very intentionally coincided with each other. Again, that's only for current enrollees in Medicaid, so if you are new, you do not qualify for the 138 to 200% until January 1st, 2025. I'm trying to remember, do we have more slides? Oh, yes, let's go to action, next slide, please. Oh, wait, maybe I can pause for a moment on the basic health plan. Any questions there? Great.
Is that waiver for all kids? All kids?
On Medicaid, all Medicaid kids.
Okay.
Eligible for Medicaid. I'm gonna, here's a resource that'll go out in your pack, so if you wanna know who are the, application enrollment assisters, you can click there, there's a short list of some of our meeting rooms that are in the room, and information on how you can become an OHC application enrollment assister as well, so some information there. Let's go to the next slide. What can we do? So we have been feverishly telling everyone everywhere we go, how can we ensure that our members have a correct address on file? The important distinction here is that if at a clinic, that address, a member walks in and says, at Volunteers for Medicine, says, hey, Kat, my address, you live on 123 Happy Street. Great, I've got you at 123 Happy Street. That's not enough. We need to know if that member has moved since the beginning of the public health emergency, which would be March of 2020. So the question is, have you moved over the last 3 years? And even though you may at your clinic at Mosaic have the correct information, we need to ensure that if they've moved over the last 3 years, highly likely that that information gets updated at OHA. Well, it took 8 years, and this is also going to make Leslie smile, that specific source and CCOs were granted the ability to change addresses and phone numbers. 10 years. I hope that's your anniversary.
Yeah. Oh, no.
10 years.
What song matches with that? I know. Okay.
Yeah. So this is incredible. So what I often say, and Dustin, maybe you should plug your ears, is that at Pacific Source, we measure our wait time in seconds. Others may not.
It's a lot more.
A lot more, yeah.
And they have more numbers. We only have 75,000. All right. That's so funny. Thank you for our incredible partnership at OHA. So call Pacific Source, update your address. It's shocking how fast somebody will answer. The member needs to do that. Step number 1. Step number 2, as we go throughout this process, we cannot stress enough that when a member receives email, we need to be asking, have they received any letters? Do you have any questions on any letters that you've received? Have you responded to open letters that you've received? If you only get letter at your X facility, go there and check it. If you've got it at your aunt's house, when are you going there next? You can see that there's less urgency in this duration of 150 days before they lose coverage, but we also know how quickly this time will go till October. So important that we update it, and then we talk to our members about answering mail, and then we have any questions.
Rick?
So, I know you guys know this, but just say it, is, all that is fine if you're someone like me who's lived in the same house for 24 years. Most of our clients, when they leave, if they move like 3 times in the next month. And so this is just one of those processes that just assumes that everyone lives a middle-class, stable lifestyle. So it's inherently just unreal. So, so there's a lot of people that will get pushed off, that really should not be pushed off, so.
What's not included in here and what we're still working on are, we'll be receiving lists from the OHA about who's been contacted and in what status their application is in, and then we have to our providers. So that we assume that
well, and then providers could text,
Yeah.
call,
Yeah.
email, if they, I mean, my chart, like, there, you can, like, broaden the, ways to communicate too.
The same way we used to do this process before.
Right,
Well,
Similar.
yeah. Any social media or, I mean, I'm not thinking banjos again, but I'm just wondering if there's maybe, Dustin got it. Google banjos. But in terms of sort of a media campaign to try to make sure, I mean, well, maybe I'll ask it the reverse way. If I don't make it through all these hoops and I've moved and I'm the person that we need to find and I go in and I have an event and I need to have care, will I be denied? Okay, so,
You will be connected with somebody who can re-enroll you
okay,
at the
Okay.
hospital.
okay, very good. All right. So we've got a little bit of a safety net there. We don't want to use it, but just verifying. Okay.
Same way someone who could come in who could, need financial assistance, and that these would also be connected to resources.
Okay. Okay, got it. Janice?
Calendar.
The projected decline is of calendar year, contract run. Yeah. Okay. And then you have, I'm just thinking about our town population. Whether or not there are any strategies that OHA is coming up with, that we can, and maybe we should be the experts on that already, but I just wondered if that was part of the conversation.
From the OSHA perspective, I think that some dependent on our community certification, conversation with the house, to really do some of that outreach, I think we need to have discussions so that concrete, I think this.
Yeah, I mean, we can do the outreach, that's not a problem, we can just, let's look at how, are there some thoughts about with the tablet? Let's check your eligibility, let's see where you are in the process. I just got your, you'll get the list of the 1,000 people that month that are, and you say, all right, these are, that we know because we know them. These are the kinds of places where also just for the group, civic resources really lean in to provide support, and whatever that might mean. We're working on an FAQ for staff. We're also working on a business card that can be handed out at the front desk. Yeah, we've been to this rodeo. But if that means more, we're willing to entertain anything you might need. This is like one of those places where we are all in alignment, that we want our members who are eligible to maintain. So I'll check back in. I mean, we have these, many of them are living right now. The mechanism is not an issue, what we do. Yeah, what to do now. Yeah, I mean, to your point, you don't have to have an address to be eligible for Medicaid, right? And there are plenty of members that don't have addresses. There are lots of members, right, on their application, it's optional. Not necessary to have. The critical piece of the address is right, so we can, right, that is very.
Carmen?
I just had a question. Do a lot of the CBOs where most of these patients access support, just for wraparound services in general, are we coordinating with those CBOs, like BIM or, other locations?
We are, Kristen, Tobias, and myself, having many, many, many of these kinds of conversations in the community. And I think as our materials become more available, it'll allow for more opportunity in those spaces to
hop in our cars and be sure that people have FAQs and business cards to hand people, to ensure that's going forward. So, yes,
I would just,
I are having lots. I spoke at several events with community partners just this week alone.
I put a little plug, oh, Dustin, go.
So the Community Partner Outreach Program at OHA also has many grantees that are enrolled in CERT that's just doing general outreach, and they're heavily involved as well.
Paul?
Yeah.
Okay, great.
Yeah.
Okay, great.
So I was just gonna put a plug in for, some of our outlying areas that maybe don't have a fully loaded network of CBOs, and so making sure that we're, I gotcha. Making sure that we're really actively engaging the communities with the assets that they have. So, which I'm sure that we are, but there's the plug.
There's always opportunities. There's a lot of, and a lot of members.
Awesome. Okay. Ta-da, we're, okay, all right. Okay, thank you. That was a lot of information, and appreciate just the interactive conversation there too. So do we have, I see Andrea, hello. So I suspect, we have a PowerPoint, it's in your packet, but we'll get that prepped here, 2 shakes, and then I am turning it over to you. So as soon as you see the screen change and your presentation pop up, feel free to take the floor.
All right, thank you.
You bet.
All right. So I think that some of this leads right into the conversation and where it was ending just a second ago. Many of you know me. I've come and presented to you in the past. My name is Andrea Kettlehut. I'm the Quality Incentive Measure Program Manager at Pacific Source, and I'm based here in Bend. So let's dive in. The state has created a new metric called the Social Determinants of Health, and it is a 5-year metric. It goes from 2023 to 2027. So where are these coming from? And you'll see here, this is a snippet from an OHA presentation, part of the 1115 demonstration waiver. So the 5-year demonstration waiver that started this last year. The state's really making a shift to what they're calling upstream metrics. So these metrics are really focused on those systemic issues, those systemic challenges that impact health. And so their idea is by addressing them upstream, that through this work, we can prevent some of the downstream effects. So this particular measure is one of them. So these new quality measures, the state's creating what they're calling these upstream measures, and then we'll continue having these downstream measures. So these measures that we're really used to around immunizations, well-child visits, you know, those really kind of standard quality metrics that we think of. And so it's through this work around these these upstream metrics that we're going to talk about the social determinants of health metric. All right, so social determinants of health, like I said, it's a 5-year metric that starts this year and ends in 2027. It is a process measure that turns into a performance measure in later years. And really the premise of this measure is that CCO members' social needs are identified and addressed through a no wrong door approach, focused on 3 domains: food, housing, and transportation. So that's really kind of that overarching goal. Next slide, please. So what do these next 5 years look like, and especially these early years? Our goal is to build the structure around social determinants of health work. And I know this work has been going on for a long time, so it's really how CCOs start capturing and measuring and receiving this data. That's beginning capturing that work. A lot of our work is also going to be really focused on increasing community-based organizations' focus on food, housing, and transportation, standing up new contracts and increasing that capacity for those community-based organizations. And then sharing data and what does that path forward look like? So these early years, this year, next year, and even into the 3rd year, are really about building those foundations. So if we go to the next slide, My slides are gonna look very simple compared to Trisha's really in-depth slides, but when you look at this work through the many elements that are in these measure specifications, there's really 5 pillars. So there's a number of policies that we must create, and it's informed by members. We must work with our community advisory panels, the CACs, to help inform how often do they want to be screened, who should be screening them. There's a number of components there. How do we work with our community-based organizations, and how do we contract with them? How do we increase their capacity? So that's the second pillar. Performing an environmental scan, understanding what's in existence in each of our CCOs and in our communities. How do our rural communities differ than our urban communities? What services exist, and again, where do we need to expand that work? Screening entities. Who is screening? What tools are they screening? Does it make sense that everybody screens, or do we want to focus it on only certain entities screening? I think there's a big question mark around that space. And then, of course, the information technology components, the community information exchange, Unitas has a role in this. The health information exchange, all those kind of technical platforms, where do they fit into all of this? And how do we take that data and take some of those different feeds that we receive, data feeds, and really start staging those in a way that helps demonstrate some of that need and those referrals. And again, all of these foundational pieces, especially in these early years, is to continue to build on and enhance what is already existing. So we know that this work does exist. Again, it's just CCOs are stepping in with this new measure being placed, in the quality incentive measure program to really start capturing and demonstrating this work. Next slide. So what does year 1 look like? And again, I've got year 1 and year 2 in this slide deck, and then we'll keep reinventing this as we go on. Q1, we spent a lot of time internally breaking this measure down, understanding the many elements. There's 15 full elements. We've started to already engage our community advisory councils to understand, again, what are their needs, what are their lived experiences. And then you can see the work that we have built out for Q3 and Q4, really start engaging our community-based organizations, understanding some of those environmental scans, and then start staging some of that technology components and understanding, what languages, what tech languages are being used currently, how do we ingest and stage some of this different data. And a lot of that technology work will be really in preparation for future years, but again, that we're creating these plans and starting to do this work. If we go to the next slide, it really takes a look at year 2, 2024. Where we'll keep expanding, right? Each year builds upon itself, and we start scaffolding up so we can, start and then really continue this work as it goes up each and every year. So again, in year 2, we'll refine those policies, and then it is a continuation of year 1's work. So we continue that ripple of engaging our partners and our community-based organizations, increasing the capacity and really designing a multi-year plan of partnering with community-based organizations. On the data sharing, again, continuing to expand that ripple and the type of data that we ingest and what that looks like. Also pulling in internal data that we have. How does REAL-D come into this? How do race and ethnicities, different race and ethnicities get screened? And what does that look like? How do we be culturally appropriate as we do this screening? And always keeping kind of the members at the center of this work, continuing to re-engage with our community advisory councils and bringing them back into that fold. And, you know, we, in years 3, 4, and 5, continue to kind of go through this cycle of building and growing this work. So it's pretty neat. It's exciting. In many ways, the measure specification is very well defined, but it also allows each CCO to really chart their own path and determine what's right for that specific region and that specific CCO. So we'll get to refine this and really make it customized for each of the regions as we move forward. One more slide. I think it's just a question slide. Any questions from you? One thing I did think about, you know, as a board, what would I hope for and anticipate from all of you? And I think just kind of keeping this in your mind as you know, work throughout the community and in each of your respective roles. And what does this look like as we expand and support some of these different community-based organizations throughout our communities, and especially as they work on these 3 domains of food, housing, and transportation.
Brad, dive in.
Hi there. I have a question. For some reason, I'm getting hung up on the word screening. Could you just, it's just not gelling in my mind. What are we talking about when you talk about the Community Advisory Council doing screening?
So the Community Advisory Council is getting to help inform the policies around screening. So making sure that they have their voice of how often should an individual be screened for social determinants of health as they go to their primary care provider or their dentist, or, you know, behavioral health, or, you know, all the touch points that they receive from the healthcare system. What should those screenings look like? So it's really, there's a number of different screenings that an organization can use, but trying to screen for food security. You know, does a patient have food at home? Is they adequate food at home? Do they have transportation when they need transportation? So it's asking our CACs to help inform the frequency, who should be asked, who should this data be shared with as they are screened for services. Does that help, Brad?
Yeah. So and that's providers that would be doing the screening. Is that correct?
I think that's the premise. I think some community-based organizations also do screenings. And I think that is the work that we have to do through this kind of environmental scan of understanding and trying to get our arms wrapped around who are all the different entities throughout our communities who do this work.
Okay, so not just healthcare providers.
Correct. It doesn't, okay. I don't believe that it lands just in healthcare. Rick, I think I saw your.
Yeah. So I'm really, you know, I've known this is coming along. I haven't really paid attention to it, and now I'm like listening to you, and so we go through year 2, and we're just trying to get data, and then somewhere in the next 3 years after that, we're going to try to shift that data and make an input, or are we just admiring the data?
So in year 3, at the end of 2025, we will send our first data feed to the state. And so at that point, and we'll do some of this pre-work ahead of time, but we'll be looking at three rates: percentage of members screened, of those members screened, what percent of those members screened had a need identified, so that's your rate 2, and of those members who had a need identified, how many received a referral is your rate 3. So we'll be working on those deducing that logic and all that data down to kind of three rates that we'll work with the state on and start communicating and sharing that with the state. I think that is part of the scaffolding and part of the work that each of the CCOs, that we'll have to figure out of, based on, of course, what the state determines as our benchmark, what is a reasonable rate of members being screened? What is a reasonable rate of members being referred for services? Does it make sense that all providers screen? My personal opinion is no, I don't think that makes sense, but maybe hitting those, working with those providers who touch some of the most vulnerable and that we know have some of these challenges in their lives, and starting to kind of lay those processes and, what does screening look like and how do we refer for services, and somehow figure out how to share all this data back to Pacific Source. It's going to be a work in progress. There's a lot of work in these measures.
I think I'm sort of missing a part of it. It's probably just me, but to what end? Like to where? So we're going to screen, and then I say, I don't have transportation and I'm currently unhoused. Would you just say,
well, thank you very
I'm
much
sorry, and then you go, I'm not trying to be flippant, I'm just so we're going to capture this information, someone just was vulnerable with the person sharing, and now we're going to do what with the information? Is there I'm sure there's an idea. Are we plan to take money out of the global budget and invest in it?
I don't think so let me answer the first part of the question. The goal upon screening and a need being identified is that these members are then being referred for services. Now, that all sounds very simple. I think to your point of how do we continue to ensure, expand, invest in community-based organizations so they have the capacity to do this work, I think that is a piece that we're going to have to figure out of what does that look like. And there are some requirements. I might punt it to Erin, around the shares initiatives and some of the different community-based initiatives that the CCOs must invest in. But it's not, there's not a direct roadmap as to how we're going to continue to grow the capacity of our community-based organizations.
I mean, that's part of the reason that the roadmap is as long as it is that we were supposed to show that we're able, after the 3 years, to screen, refer, and close that loop on that referral to ensure that the member actually did receive the service. But to Andrea's point about so much work, a big part of it is going to be about, do we have the referral pathways? Do we have places to which we can refer? What does that workflow look like, and how do we ensure that the organizations that provide those supports and services are able to get reimbursed for any services they render for CCO members?
Yeah. So then Carmen, Miguel, Janice, Dustin, maybe? Did you have your hand? Okay, all right, okay. Go ahead.
Okay, hi Andrea, it's Carmen. So I think mine is more of a logistics implementation piece. We're in Q2 now for 2023, and so are we, is this an agenda item that needs to go to CAC, and how do we start having those conversations?
So I think that's something Tricia and Kristen and I need to put our heads together on. I have presented this at the Shared Lane Community CAC over in Lane County. So we have some of those slides and some of that built out, but I do think that that's the next step and that we need to get on that agenda.
Okay.
Should I move that?
Or we can just hand you a microphone. Rick, that's what that is on the end of the table.
Andrea, this is Miguel. Can you hear me?
It's coming to you.
Wow, fantastic. Hello, Andrea. This is Miguel.
Hi,
So,
Miguel.
The model of social determinants of health lives inside a bigger model, which is social determinants of equity. And it's a little like social determinants of health is an expression of the inequalities that are created when you analyze the social determinants of equity. That includes segregation, lack of education, etc. Bigger points that are the drivers or defects on or in inequities on the system itself. Are you considering to include some of these areas around social determinants of equity that are defined by OHP, by the way?
Great question, Miguel. It is part of the work that through this work and through the trainings that the CCOs are required to offer, that this work is being performed and being held and being done in a culturally appropriate, trauma-informed, equitable manner. So that is definitely the one of the biggest priorities, I think, through all of these new upstream metrics is the recognition of health inequities. And it's something that needs to be kept at the center of this work.
Excellent. Thank you, Andrea. Janice.
I'm going to apologize in advance if I sound a little cynical. No, so I think you introduced the concept, Miguel, of a larger social construct. So here's what I'm experiencing increasingly is that the burden of solving social ills is being laid at the door of the health system, period. So you're going to ask my staff to complete yet another form to tell you what we already know, which is that our people are poor, unhoused, inequitably treated, don't have adequate access to care or quality education, or a host of other things. We can do that. We play that game all the time. And then you're going to pay me to make a referral and close the loop on the referral, which, by the way, is another piece of work that I have to pay someone to do other than provide a service, which is what they're trained to do, to tell you that I made a referral to an agency that is paying low-staffed individuals to try to connect people to resources that don't exist in our community because the larger system has made choices about how to invest money. This just is incredibly distressing to me.
Yeah.
And it is a way that we cause poor people and the people who serve them to fight for limited resources. So you bet you this will come out of the global health budget, which is already stretched to meet the needs of poor people. And I'm just feeling some fatigue. I don't want to ask staff to do one more thing to tell you what we've been telling the system for years, which is that our people are really poor and that we continue to have income inequality that is growing and growing and growing. We can't figure out how to solve the housing problem. I struggle with this. I get the idea. I get that we need to measure things, but let's measure things we can actually make a difference on. I don't know that out of behavioral health or an FQHC, I can do anything other than refer someone to another poor agency that doesn't have enough resource to solve the problem either.
Yeah.
So what are we trying to do here? And how do we use this data to actually challenge the system to take good care of our entire community?
And I think what you raised is, yeah, exactly. How do you tell the why and engage the why with your team into actually engaging in the screening and the involvement and all the things? And so do we have an answer? Is this, what if we don't do it?
We probably have to do, we're not going to.
I'm just starting with, but let's get bookends. What?
Yeah, do we have to?
Yeah, do we have to?
And Andrea could probably speak to this more than I, but some of this came up as they were managing or signing
and the state not necessarily knowing, trying to use their community committees to come up with
these specifications and whatnot, and they got a lot of feedback, as you can imagine, like it's another screening, we already know this information, things like that. But, you know, what the state and all of us have learned is that when you incentivize a metric like this and you put $1 million plus on it, the work will get done. And this community has shown that year over year, with the exception of 1 year. But
those metrics were things we could actually, I mean, a lot of metrics measure things that we're actually resourced to provide, and housing is one of them.
No, I don't disagree.
Or transportation even.
I mean, we could use the entire Medicaid revenue, and we would still have a houselessness problem.
Well, a housing problem, not just
a housing, of course, So I'm gonna, I think we bookmarked that, because I don't think today we're gonna say, too bad, so sad state for going to different services. But this is a whole lot like the framework around the modernization of public health. And there is an initiative that's running at the same time, and that's OHA's budget for public health. And part of that is being carved out for CBOs. And one of the recognitions is that the CBO network raised earlier is not fully established throughout the state. And so
That's an understatement.
Okay.
Yeah, we're sitting in Jefferson County, and they would definitely say that.
So we call that an amen. And so my thought here is that as we are messaging, there's a partner here that's missed in this documentation that is actually, I mean, the counties are the boards of health, and the premise that everywhere in Oregon we should have foundational capabilities to be able to meet the needs, which are very similar to what has been laid out in this particular diagram. And so I might encourage us to think about the consideration of making sure that our public health partners are reflected in this work, because they're doing that work every day. And it also, as a board, you know, we have Rick, who's representing behavioral health, which is a very specific and important and also sort of, partner in the health piece. Our public health partners may need to be engaged a little bit differently around this table as well. In the past, they've been presented through commissioners, sort of wearing all the hats. But with all of the hats and with the new initiative of thinking about social determinants in the CCO framework, we might want to look at what our board composition looks like in that space too. So I just want to lay that sort of at the table of how we maybe increase that voice in a way that helps us to achieve and answer some of these questions, and how we might create a framework that actually gets it done. Yes?
Yeah, so, you know, in the small counties, there isn't a like you were saying, there isn't a network of groovy nonprofits doing groovy things like there is in Bend. And there might be one person stationed by a minority of the nonprofits. So the real work happens by county-based organizations. That's just how it is. And then we have these debates with the Valley that just doesn't, you know, people in Portland and Salem who don't get it. And and it's incredibly frustrating. And then I would also, I've had a very interesting last few weeks having discussions with OHA, because they rolled out culturally and linguistically specific payments, and initially said that our Latino program wasn't included. And you start debating with them, and you say, well, you know, in Oregon, we have the lowest access in the country to substance use treatment. And if you happen to be Native American or Latino, your access is about 1/5 at best. I mean, we have a totally two-tiered, segregated system. In even the system I'm in, you want to talk about Spanish language specific mental health services, we're talking individuals as compared to an industry. And that's built on decades of decisions in the state of Oregon. I mean, it's, you know, and you start debating state workers about this, and it's like, you know, it's a segregated system. You know, if you're white, you're wonderful, but it's not.
That's high praise.
It's not intended. I mean, our system is well-intended people, but this is the result.
Yeah.
You know, in Oregon, everyone's polite, everyone's well-intended, but our results are crap, right? And
we're sitting in the least healthiest county,
right,
city,
and
state, and
right.
that should be unacceptable for us.
Right, despite having one of the most progressive and energetic public health directors in the state.
Look at you just be full of sunshine and praise. Wow.
So, you know, and I think as a lifelong resident of Oregon, we've never really confronted that real extreme racial inequality that is inherent in our history.
Yeah.
And has, and I've sat, I mean, you know, and so one of the frustrations of the current language out of the state is my concern is too often it's an emphasis on woke language and not following up on actual change in services and policies. And so it becomes a window dressing. And I think that's a real danger of that. And so, and you know, I've run this Latino program here in this county for 21 years. Most of that time I was mainly concerned about ICE raids and getting closed down because we were serving Latinos. So, you know, if the state of Oregon is going to, you know, finally sort of acknowledge that in their language, you know, there needs to be real investment, or it creates even greater cynicism. Frankly, at this point, I was happier worrying about ICE raids than I am with people talking all woke and not following up. At least I knew where my enemies were.
But look at the numbers, though. I don't know if you all read the editorial in the Bulletin on Tuesday about legalizing all these drugs. The overdose deaths in Deschutes County in 18 and 19 were 14. Last year, it was 28. We had someone overdosing and dying every other week in Deschutes County. We are the second most addicted state in the nation. I'm a native Oregonian. This breaks my heart. We're the second most addicted, and yet, as you say, we're 50th for residential treatment beds. And I just see what's happening now, and now they're using a horse tranquilizer on top of fentanyl, which is, no. I mean, as my equine veterinarian said, I can no longer give that medicine out because I am so worried about what's going to happen with that. So, I mean, I look at it and I think, why are we so addicted here? We actually, on this side of the mountain, live in the most beautiful place, and normally we have 300 days of sunshine. I'm not sure about this year, but, you know, we are so lucky, and yet so many people here need those drugs. And I think it's really incredibly unfortunate, and, you know, what do we do to change the way our whole state is going? And I find it incredibly challenging, and I know Janice does, with what she, you know, what we live and breathe every day. But thinking that we had someone overdose every other weekend just makes me want to cry in Deschutes County. I don't think Jefferson's numbers were anything like ours were. But
Not exactly, but we are.
Unfortunately, I mean,
the numbers are drastically increasing here, and each death here is a greater percentage of our population in Deschutes County. So outstanding measurement for Jefferson County. Chair Fanny mentioned, the county health rankings, and once again, Cheek County continues to be one of the healthiest states, the top 5. Crook County, right around the middle, 15, 20-ish. Jefferson County, ever since the measurements came out, was in the bottom. We're still the bottom. We're falling lower. The only time we're not the bottom, but the other smaller counties have less data to compare to. So that portion, that personality is just, and we're so connected. How can that be?
Yeah.
We're talking about it. Social determinants of health.
I'm so glad you're here, though, Dr. Baker.
Sorry, but now I'm. So, when talking about social determinants of health, that's what public health does. That's what we've done forever. We at Jefferson County Public Health did a partnership with OHSU and OCHA and EPIC on social determinants of health. And we found that nearly every single client that came into public health qualified for some kind of system or some kind of service. In Jefferson County, it was a dead end. Yes, you need it. Yes, you do this. Where do we send you? Nowhere. There are not enough food boxes to be handed out to address food deserts here. There is not enough public transportation system that will ever help. We tried to limit it by creating the health campus where at least you can come here, we can get you. But once you leave here, where do you go? And that is so frustrating on so many other levels besides patient care, all in equity, all in access. Everything we talk about that we're trying to eliminate. We live it every day, we see it happening somewhere else, and it just makes it even more frustrating.
Nope, that's good. I mean, why we're here.
You're not done.
Katie, go ahead. Go ahead.
Since I started in the administrative role in Curry County, I've been in meetings with other public health administrators, mostly in rural communities, who are frustrated with Oregon Health Authority typically. I've tried to
Except the representative here.
It's not typically at the program level, it's typically at the upper echelon. And it's about blanket programs that are applied statewide. I have tried, I share those frustrations, and in order to not burn out, I have tried to shift my energy, the majority of my energy, to what can I control and what can I influence. So I'll bark at them, but also, what can I and what can we influence? So on the question of why are we as Central Oregon not investing the money that we have control over in Jefferson County? Why are we okay with continuing in status quo when we know what the numbers are? We've seen the data, we know the inequity that exists in our community. Why are we not doing what we have influence over to change that? I guarantee if we make that change, OHA is watching. As people watch Central Oregon, we set a tone in our community. Why are we not making that change? I'm sick of watching it. As a public health professional, it infuriates me to my neighbors watch traffic fatalities, overdoses, firearm violence. Go Google the rates. It's horrific. Mortality rates for children in Jefferson County.
Thank you.
What do we do?
Yeah.
Within our control.
A great question. Hold that thought. Brad, did you, please?
Claire, so are you referring to county budgets, or what do you, how that money's allocated?
Or even our, it was like the CBO thing came out from the state, and they didn't have anybody here that could do that. And Commissioner Sumlick is like, Patty, you've got to say something, and because, and we did try and say a lot about it because it is part of our community. And I see it, and I know that Dr. Baker works with our epidemiologist, and, I really hope that we can share as much, our resources as possible, because I really feel like we're in this together.
Well, the unintended consequences is the resources will go to communities with CBOs, which are already communities that are well-resourced.
Yes.
And the data collecting and the cost of data collecting will be to everybody. So we'll get the expense of collecting the data, but none of the resources, or fewer of the resources, because you don't have the CBO structure. And so, and that's really sort of part of Janice's concern, I know, is data is an expense. And so you are responsible to do something with that data or stop collecting it. And what we have in behavioral health is it's incredibly notorious that they collect massive amounts of data and they put it in the wastebasket. They never do anything with it. There's no feedback loop at all. It's just an expense and part of the stigma of the system. And so the concern is that this initiative, totally well-intended, will have that further unintended consequence. And the result is what we've done over the last 5 years is really shifted more and more. We've become more inefficient in behavioral health with our dollars because we have to do more and more reporting.
Sure.
And then this layers more reporting onto that, which again creates greater inefficiencies and degrades services. So even though we've had all this nice investment, there's just these crazy unintended consequences going on.
Can I just have one quick thing?
And then I'm going to need to bring us all back to the actual.
What Katie said about safety, if everyone in this room would send an email to Congresswoman Laura Chavez DeRemer, she is on a transportation committee. I had said to her office months ago, we need 97 fixed. It is one of the worst and most used highways in the state. And, they keep talking about a bridge over at Portland, and I'm like, no, we really deserve that. So if everyone here would send Lori, get a hold of her office, and just say, you're on that transportation, please get us something for our highways here in Jefferson County. So you see it all the time, the accidents that happen. It's so dangerous, So anyway, that's something that I put in for a long time ago. They said it wasn't on the plan, and I go, oh, for gosh sakes, look at the accidents, look at what has happened, and it should be on that. It should be funded. So, but it takes hearing from an important group of people that care, and you can make a difference. Because, I'm fighting I say send the water to the farmers, in North Unit. More food is raised in this county. It's unbelievable, and they're part of our team.
Great point. Please. I just wanted to add two things that I took back. I just recently came from a conference in Chicago, and I want to just speak to data. I want to speak to data and community investment as a health system. So the one takeaway that I took was that we keep gathering data with the same results. We actually already know the outcomes, and even in the equity spaces, they're saying we're not going to do an assessment in our community. We know that we're disenfranchised and we're marginalized. We already know that we need to focus on poor rural communities. And so there is a movement around that. It's also a systematic piece that says, I need to prove quantitative data to say that I'm right. Or, you could switch data any way you want. So I guess what I'm asking is there a space or opportunity to experiment in that space? Because we know the outcomes of most data, even though we're collecting for raw, right? Because we have to. But we have to. It's an accreditation requirement for the county. All the things why we have to do it. So I guess I'm just posing that as could we pilot a space where we're not necessarily having to do all that? That's my first comment.
Yeah, and I don't want to come across as a data person. I agree with that.
Right.
The data we collected. Over things where I think we have more ability to have. This is the phenomenon I think that I'm concerned about. We get to measure social phenomena and we have to determine really involve systems that are beyond. So could we play ball, collect data, because we're going to have to anyway. But can we be more strategic about it? So that as we're collecting data, we're looking more towards what are the actual things that we have, what are the systemic changes that need to occur that we can direct health make. We're not doing that, and I know that's partly wrong, but I'm just tired of observing the problem 6 ways to Sunday, so that they,
Right. Just
Go ahead. Yep.
I know you're trying to move it back.
Well, we're covering the next agenda item really well.
Yeah, and I've already got a plan, so
Okay,
don't
great.
worry, nobody panic.
And then last but not least, the second piece was there's, I think it's called Rush Medical System. They're a hospital system in Chicago. And what they did, they have a new CEO there. He used to be the chief medical officer. And what he said in front of all these thousands of people, he said, we're losing $224 million this year. My board is pissed off at me. He goes, but I don't care. He goes, because we're investing in the community with our local partners, our behavioral health and, CBOs and all of these other partners in the community, and they have invested community centers. They're going to where the people are at, in the rural spaces, and they invested centers, and that's where they're putting their money. And they said, this is the only way that we can do this, because we want to get people into hospital. We need to survive. He goes, but we're trying to prevent people. We only want the people that are in catastrophic cases. We're taking care of their chronic diseases. And it was pretty amazing. I was really inspired, and I just think this community has the opportunity to do that. So anyway, that's my 2 cents, and it's not a dream. It's an actual reality in a lot of spaces in the country.
So Andrea, if you're still with us, which she might have, oh, there you are. Thank you very much for bringing this forward, and you've clearly brought forward a really important conversation for us to have as a region. The answer is we absolutely will meet this objective and then probably crush it beyond, but I think what it's raising is that there is a challenge with CBOs, and I would say that it's not in lieu of, it's in addition to, that we need to be supporting our public health network as well. And I would submit that maybe we could set up a small ad hoc committee of the board that is just around this social determinants of health space with our public health folks, and find a way that we can maybe make this a wee bit more meaningful. And if there's a pilot to be had, I think that we could use some of our flexible dollars to be able to invest in something. But if there's a way that we might want to, so I'll throw that out to the board. We don't have a quorum, so, but is there?
I think we do now.
No, it's okay.
Okay.
So you all get to have the consent agenda from this month on next month too. So if that is okay, I'm seeing some heads nod that would be good. Maybe with our public health folks, with being involved, we could, bring it in and chat about how we might strategize something. There is a discussion that Carmen and I have had about the carve out for behavioral health, if we maybe don't need to be looking at something for public health. If we want to achieve outcomes, we're going to have to invest toward it and not anticipate someone else saving us in that. So next item, Dan and I are going to spend about a half hour, I'm kidding. Dan, I know that we are partners in crime on this. Good to see that you're still in your cell. And I am going, because we don't have a quorum and we're super light on board members, I'd like to throw out the following. I did create a small PowerPoint. It's just actually a document that has the tenets of our past strategic plan. So it has the sort of how the pillars fit in with our overall strategies, with our overall actions, and then we have our aims. Put it all in one document. what we're hoping to do is have a conversation with the board in June at our strategic planning session about where we have been, about half-day talking a little bit about are these the pillars? Are these the right aims? Are these the right strategies? Are these the right, is this the right context? And then in the afternoon, talking about let's do some visioning. What's missing? Is this, if we felt like maybe there were some gaps, let's talk about what's missing. Maybe it is in this public health space. I'm not sure. But how do we look at, page 20 is, and I'll ask Kelly we could send it out after in a separate email. But it just takes the aims that are within your packet and puts them with some of the graphics that we've used in the past for our strategic planning efforts, ties it together a little bit sort of in what that framework looks like. Here it is, ta-da. So we then have our pillars that we identified and how all of those pillars fit in with our strategies, and then next we have the actual strategic directions that are coupled with those strategies too, and some of the language around it. And then in further detail, then we have those drawn out with the strategic directions with the aims. So my ask to the board members is that you are getting a preview of the homework, which will be full homework for the full board for May, so that we're appropriately prepped for the June timeframe. In May, I think what we'll do is if you have an opportunity to review this ahead of time, do a little bit more of a deeper dive there to gather some information, so we're not just going into the June meeting without any real known interest of where you might want us to be going, so that we're not entirely caught off guard and can prep for June in a better way. So with that, Dan, partner in crime, does that work for you?
Yeah, it completely works. I think that was really well laid out, and that sounds like good prep work and a good conversation for May leading to June.
Okay, awesome. Whitney.
Next, we're going to turn it to Miguel.
Wonderful. Okay. Please come on up. Yes. And I do know that we will be running a little bit over, so my apologies if you need to head out. We understand, but if you can stay, all the better.
Okay, we are going to get sure on this. Thank you so much.
Yes.
Having us. So we are going to give an update on collecting information. So.
Ta-da! Good segue.
Great timing. But there is a plus. Don't worry.
Well, the plus is you.
We have actions around it.
So the plus is about what we are doing around the regional health assessment. This is a reminder, and then some actions for the board members. So around the regional health assessment, as you may remember, Whitney explained last time that we are acting on with three different components. The first one being secondary data, which is basically what we can have from data existing. That's basically the corpus that we have in the past. And we are adding more robust information about two sources of primary data. The first one, community health surveys, and the second one, listening sessions. Again, Whitney explained the other day, last month, on detail how are we proceeding with these two sources, and our request today is around the survey. So this is, again, just a reminder about what is our work plan timeline, and we are already going into the listening sessions. We have a little more than 200, and basically without pushing too much, because the media toolkit is just releasing this week, so this is fantastic, more than 200 surveys that we have. The listening sessions are programmed for June, from June to August, and the only date that we need to keep in mind is that the report needs to be finished by January 24 to have the entire 24 to do the rest of the process. So so getting into the survey, what are we doing? How is that working? So basically, we have one part with community members. So we are getting community members themselves that they are engaging to push the survey, and we are paying them, the individuals, up to $5 per survey, up to $500. And we have already some of these people engaged. A similar idea with community-based organization, except that, again, we are paying $5 per survey collected, and they are up to $1,000 for community-based organizations. And it's working very well, so people getting very enthusiastic within the link of the survey. Every individual or community-based organization have their own QRA and link, so we can know from where it's coming the survey, and they put that on the flyers or announce them on their event, etc. We also have a social media campaign with paid announcements, and also public service announcements that are considered to get the survey out. So now, if you remember, last time some of you decided to get into the contest, to have a dinner provided by us, by the Central Oregon Health Council members, right?
With music?
Carmen
Okay.
proposed to be the chef for that day. I proposed to be the musician, accompany the music, etc. So we have a promotional tool now ready for you, for those who want to get into the contest and support this very important part, the survey, because yes, I know we talk about collecting information, but this is different because in the past, if we just rely on secondary data, and we are missing a lot of detail that we are working in the survey. We work the survey with a lot of detail to focus particularly in social determinants of health, and we are collecting information that we cannot get from this secondary data. And on the listening sessions, we are going even further because we want our listening sessions to be also an opportunity to connect with communities and to begin to build what is needed to drive further collaboration with the organization. So LCA is an example of that. We are doing work with them right now. So we have already our promotional kit. It has flyers, posters, video monitor graphics for those who are able to do that in their organization, postcards, social media content, and a newsletter article. And in the past week, I think in the past of the week before, board members received an email from Whitney, so asking to get into the link. This is an example of how the media kit, how it looks like, with the logo, with the, this is basically, so there's different presentation of that according if it's the logo, if it's the slide for the screen, etc. But for the screen, just use them as
The other pictures.
We contracted with, and these are the prices of the people is getting.
Wow.
We just get 7 winners for the first month. That they can choose whatever they want. An iPad that was in collaboration. We get some iPads from Charles, Mac Mini, and money. So 7 winners every month. That's really the benchmark. So what is the board members? How can you support this work that we are doing? You receive an email from Whitney, and what we are asking, the action item is to sign up to receive the toolkit for your organization. You don't need to sign yourself if you don't want it, because you have a person, a manager that will get involved. So, but we need that information to continue working with that.
If we pass it to the manager, do we still get the dinner?
Yeah. So
Yeah.
you actually get
Yeah, so I think what we're gonna do is give an organizational, so it's an organizational contest too, if you will, like, you know, CYC. Yes, Mosaic.
You're going down.
But I think we were also talking about, like, how do you embed this, you know, in the waiting rooms, like on the screens? Because they're all QR codes, social media, everything, But,
on designing communications and running the social media campaign, because Miguel and I, though we agreed to other duties at the time, we don't know how to do social media well. And so through our Central Oregon Health Council social media, we're tagging a lot of different organizations. And so if you're wondering why Central Oregon Health Council keep tagging us, it's because we want you to promote those posts too. And we will not stop tagging you.
Wonderful. Okay, how has the response been back from the board? Not like specific members, but,
we could use some more.
Okay, very good, all right.
And like to add some exciting information, we've had 216 survey respondents so far with very little outreach. And what I will say is 88% of County, which is too much. And we have 4.2% from Crook County, 6% from Jefferson County, and 1.4% from Klamath County. So we'll be giving updates on survey responses every month at our steering committee, and you all have staff that are on the steering committee, or you are on the steering committee, so keep coming.
and public health directors get their own QR code too, right?
We'll talk about it.
Okay.
But you have a question
Yeah, what's the timeline?
Okay.
for the survey?
Yeah, for the contest. Call it contest.
Oh, for the contest, we are gonna close
I thought it was sent, but I can't seem to find it.
So the survey is gonna continue up to the end of the work, but we need to close it before we able to close it.
Contest through August, survey to the end of the year?
Up to September,
September.
for the board, yes.
Yeah.
Whitney, could you resend that to the board and to Dan, who's typed in the chat? It came from you originally, is that, okay. But she's gonna resend it, Dan. Okay, wonderful. Miguel, thank you.
Thank you.
Kat?
I'm on this committee, and one of the things that came out was we have lots of responses from 50-year-old white women.
Oh.
We need more diversity. Currently, 80% of our respondents are women, and 20% are men.
Oh, we need more men.
Yeah.
We need more men.
Can we do like a battle there as well? I know, exactly. Right, yes.
You already know.
Oh my goodness, Katie.
Outreach material available in Spanish? Yes, it's in English and in Spanish.
Wonderful.
I don't think I've been tagged in Spanish. Yes, Spanish language ones where they're currently being translated.
Okay. Well, I believe we have come to the end of the journey. Do we have anything else for the good of the order? Anyone virtual? All right. Well, thank you. What I love about the meetings, and especially now that we're able to sort of be hybrid, is the energy in the room about the system that we're trying to improve, and we know it's not where we want it to be. And there's no fault here at all, but I really appreciate the genuine and authentic approach that people are taking so that we can achieve some better outcomes. So thank you all for being here, and we're adjourned.